We are all part of it. All the OPD services, operative services, we have stopped. And this is the time.
We begin our talk today, management of thyroid cancer, the traditional guidelines and the recent advances. I have not kept a separate talk for recent advances, so we will be incorporating all these recent advances alongside the main lecture. As we know, the history of thyroid dates back to the excavations of pyramids. If we trace the formal history of thyroidectomies, the first operation of goiter was done in as back as 1000 AD. Then eventually we managed to get the techniques better, and by 1861 Billroth did 20 thyroid surgeries, out of which actually 8 died of sepsis. So he stopped doing the thyroid surgery, so much so that in 1860s Samuel D. Gross in Philadelphia said that it's a horrid butchery and no honest and sensible person would ever engage in a thyroid surgery. So you could see that there was such a huge problem and fear with thyroidectomies. In 1867, with Lister's discovery of antisepsis, Billroth again started slowly till the time when Theodore Cocker presented 100 thyroidectomies data in 12th German Surgical Congress. Following that, in 1917, a landmark happened when Cocker in the Swiss Surgical Congress shared his experience of 2000 thyroidectomies with 0.2% mortality. Till that time, it was considered to be a very taboo surgery, as we all know, but advancing techniques was the theme, and as we'll see later on also, this has continued over a period of time as it has done with all the surgeries. So the Nobel laureates who made the difference were Billroth and Cocker. Billroth was a teacher of Cocker, initially the one who started doing thyroidectomies on a large scale, and then Cocker, who was absolutely an epoch-making surgeon. Then came the great William Halsted. He revolutionized surgery by insisting on skill and technique rather than brute strength. And the extirpation of thyroid gland, he says, typifies the supreme triumph of a surgeon's art. Uh, why are we discussing this as students and potential practitioners in the next few years' time? It is because the comparative evidence suggests, the CA data suggests that it is the fastest rising cancer in the USA, and that is broadly reflected in the data as in India too. It does not mean increased mortality, but increased detection. Multiple factors have led to it, including screening programs et al. But beyond the point is that the incidence of thyroid cancer is increasing. The Globocan 2020 again showed that in females it forms a significant portion of cancers that is happening all over. Now, why was this generally an ignored cancer? It is because even though the incidence kept rising, the mortality has more or less remained steady. So people, even though people are detected, people are not really worried about them, suffering from the dreadful consequences of mortality or extreme morbidity. But over a period of time, it has become just the better management that is there. We know broadly what is the pathology of thyroid cancers: papillary, medullary, follicular, and anaplastic. I won't dwell on to that because we have more important topics. But as we said, that mortality is exceedingly rare after a good initial treatment. Only a small person even develop a locoregional or a distant metastatic recurrence without with any impact on survival. So this is the data, retrospective data from MSKCC. As we see that age was an important criterion here, and age became one of the important points where successive AJCC classifications also tended to improve the age as a criteria. This is just a broad, we'll keep referring to this as we go on. This is just a broad outline as to how you treat a thyroid nodule in your clinical practice. When there is a suspected thyroid nodule with a normal TSH or an elevated TSH, initially we go for an ultrasound. If there is a nodule, we do an FNAC. If there is not a nodule, then of course we just continue ultrasound based screening. If there is a nodule, based on Bethesda classification, this is broadly it. We don't need to dwell on every single aspect right now. These things will get clearer as we go along. The systems that have been developed again are the thyroid system. Most of you might be aware of the thyroid system. If your institute does not report your thyroid nodules in terms of thyroids, please insist your pathologist and your radiologist to be on the same page and move toward the synoptic reporting, because we are coming up with a large series of Indian data also, where a thyroid system will help all of us come on the same page and publish a large bulky Indian data. So for your later practice also, insist on being on the same page with your pathologist and radiologist. So these are the points again that you can see in ultrasound, and then add points for thyroid level. It becomes a TR1, TR2, TR3, TR4, and TR5, based on which your management of thyroid nodules happens. Now this is the Bethesda system. Now look carefully. This is a 2017 Bethesda system that was neither here nor there, or let's say it was evolving with time, because there was non-diagnostic, benign atypia, undetermined significance, suspicious of a follicular neoplasm, etc. With more and more knowledge over a period of time, this is the latest edition 2023 Bethesda guidelines, where it has become quite condensed. So the non-diagnostic or unsatisfactory has become simply non-diagnostic. The unsatisfactory part has been removed. You see category 4, they have simply put it as follicular neoplasm. Again, there is a WHO classification of pathology that has helped in this, which we will come to later. But for now, what we need to know is that the Bethesda is constantly evolving. The risks of malignancy are evolving, and as you can see, that it is recommending molecular testing in more and more cases of Bethesda 3, 4, and 5. A new entity that has come to all of our notice is NIFT-P over the last few years. What is actually NIFT-P? So the full form of NIFT-P, for those who don't know, is non-invasive follicular thyroid neoplasm with papillary-like nuclear features, that is NIFT-P. It's a new name for very low-risk thyroid tumors, which was initially classified as encapsulated non-invasive variety of carcinoma. The key feature is carcinoma. It's not a carcinoma because it's not, there is no evidence of invasion. They just have a follicular growth pattern, right? The entire tumor capsule has to be reviewed before we stamp it as NIFT-P. Then it cannot have any necrosis or increased mitotic rate, and the tumor must have no or minimal papillary appearance and should not have the appearance of any other cancer variants. So if that is the case and we stamp it as NIFT-P, it means that even a hemithyroidectomy for large tumors is good enough for us. Uh, the most contentious topic these days is the molecular diagnostics. Every institute has different protocols, because the standardization has not yet appeared. ATA guidelines are going to come in 2025, where we expect some more clarity in with regards to guidelines. But as of now, these are just recommendations, and again, all institutes based on their patient demographic and patient characteristics have their own protocols. Because increasing number of Bethesda 3 and 4 nodules are found, we have to weigh the morbidity of surgery versus the potential risk for malignancy. So whether we operate or not should be governed by ideally the risk of that tumor turning into a malignancy, right? So then there are a number of rule in tests and rule out tests. What does rule in mean? Rule in means a genetic testing, a molecular testing that will enable us to find out whether the chances of malignancy are there or not, and rule out is quite the opposite. So the breakthrough was made. Again, I have no affiliations with any of these firms, but these are just the basic tests that were recommended initially. Now, of course, the entire spectrum has changed, and there are multiple things available. So Afirma, that was a company that showed that a prospective double-blinded multi-center validation study for 265 indeterminate nodules reported a sensitivity of 92% and a specificity of 52. As you can see, sensitivity is high, and its negative predictive value is also high for 3, 4, and 5 Bethesda. So Afirma GEC was identified as a rule out test because it's a very sensitive test. Similarly, there was Thyroseq that was available. Again, for Bethesda 3 and 4, we can see that the sensitivity was also high, the specificity was also high, and negative predictive value was in the mid range, we would say in the 77% category. So it is a good rule in as well as good rule out test. Bethesda 4 are more reliable for Thyroseq than Bethesda 3 comparatively, but still it is a good enough rule in as well as rule out test. Now, of course, there are Indian companies coming up with multiple such testing, and that is something that has to be discussed at a separate platform altogether. For us, what we need to know is that increasing the number of nodules means that we have to offer, at least offer to the patients the possibility of molecular testing before we go straight away for a hemithyroidectomy in these patients. Now pathology, the good, bad and ugly. We know that the follicular cells of thyroid may lead to papillary and follicular carcinoma. There are some bad variants like tall cell, insular, columnar, and then they lead to eventually poor differentiation and finally go to anaplastics. So anaplastics are the ugly ones. The poorly differentiated ones are the bad ones. So even then you can see that more than 85% tumors are the good tumors. Medullary is again a separate thing. It doesn't arise from the follicular cells. This is purely follicular cells. Okay, I'll just stop here. I'll just tell you that for those who have questions regarding medullary CA, of course, because this is a vast topic, we are covering medullary CA at the end, just mentioning the guidelines and basic clarity, because medullary CA is a different topic altogether. We'll cover it briefly, but that is something that we must know. The prognosis of thyroid cancer, again, as we said, that mortality in anaplastic is well known, poorly differentiated, yes, but other than that, mortality is very rare. This is an important thing that most of the trainees and most of the MCH student, ENB students must know. A WHO classification of thyroid in 2022, some significant changes have been made. Firstly, all the multinodular coitus, benign lesions, this, that, and everything that we used to see on reportings, all of them have been now termed as thyroid follicular nodular disease. Very important. Discuss with your pathologist to report it this way, because it reflects the clonal and the non-clonal proliferations that clinically present as a diverse multinodular coiter part. This is for non-neoplastic, as we said. The other thing is that papillary thyroid carcinoma should be subtyped based on the histomorphologic features rather than the tumor size alone. This is an important finding because that leads to the term micropapillary CA going out of syllabus for all of us, because it doesn't mean that a subcentimetric lesion is not to be treated and all. The new WHO classification again uses the subtype instead of a variant to avoid, because variant can be genetic variant also as the time goes on. So it's a subtype. So papillary subtype, follicular subtype of papillary carcinoma, the follicular variant, that is the thing. New WHO classification also said Hurthal cell to be replaced with oncocytic cells. As a result of this change, the Hurthal cell adenomas and the Hurthal cell carcinomas are called oncocytic adenomas and oncocytic carcinomas. Oncocytic carcinoma of thyroid requires histological evidence of malignancy and absence of high-grade features and pathological stratification into minimally encapsulated angioinvasive and widely invasive subtypes, similar to basically the follicular thyroid carcinoma. The differentiated high-grade thyroid carcinoma is a new diagnostic category that includes DTCs, FTCs, and oncocytic carcinomas, all the DTCs basically, with high-grade features associated with poorer prognosis, which is traditionally defined poorly differentiated thyroid carcinoma as per the Turin criteria. Now, the use of micropapillary C, as we discussed earlier, is obsolete and it should be discouraged from now on. And MTCs are also classified based on risk factors, so based on necrosis, Ki67, and mitosis. That is the thing to be done. Uh, so we have discussed the pathology part in extensive details, at least the surgical pathology, as we would say, what we should know and how we should deal with our pathologist. What about the imaging part? Consider CT scan to be the primary investigative modality in cases of malignancy for metastasis. Nodal sensitivity in CT scan ranges up to 92%. So broadly, if your center doesn't have extreme financial restrictions, the broad protocol for all of us should be that for any malignancy, CT scan should be minimum. CT scan of neck with contrast. You may include thorax as well alongside, just to see for metastasis. But even in a T1 case, at least go for a CT scan to see the exact location and the possibility of nodes being there. Uh, Nodal sensitivity, as we said, is high. In selected cases, MRI is indicated where you see a tissue invasion potentially in the laryngeal region or the tracheoesophageal groove and other places. You go for an MRI. In very advanced cases, and role of endoscopy in those cases of thyroid cancer that involve the trachea, there is a role of bronchoscopy, any other endoscopic invasion based on your characteristic feature, but it's a case by case thing and not a rule where you should perform an endoscopy in all cases. The basic Hopkins examination is of course mandatory, but all of you are surgeons, so you know that that is to be done in any case regardless. So prognostic factors and outcomes, what is this here? The data from multivariate analysis of 1810 consecutive cases from 85 to 2002 showed us this very famous chart by Dr. Michael Tuttle, who is one of the leading lights in ATA guidelines. So he showed that there are multiple factors like age, uh, the, the the sex of the patient, histology, and size of the tumor. So that is very very important. Again, females have a higher risk of cancer, but males have a poorer prognosis. At the age as the age goes on, the prognosis becomes worse. In follicular CA, there is a slightly lower survival rate than papillary CA, and same is for the size of the tumor. So the basic risk group started getting formed. This is the most important part. See, the surgical part, again, many of you must be experts at it. Most of you know what is to be done, but why we do it is very important. So this is what we intend to focus on in academics. So differentiated carcinoma of thyroid began to be classified into factors like high risk and low risk. Now, as per our classification currently, more than 55-year-old males with a 4 centimeter size tumor with an extra capsular extension and a high grade with distant mets are considered to be the highest risk. All others are generally lower risk groups. Of course, there is more to it than just that, but broadly we can classify this as low, intermediate, and high based on these characteristics. Then again, the data showed that over a period of time, the risks have remained the same. It has not kind of decreased over a period of time. And so there has been a changing paradigm in the management of thyroid cancer. Traditional paradigm used to be that there is a one size that fits all. We do a total thyroidectomy, give radioiodine in all cases, and all patients are to be given a same follow-up. Now we know that there are specific risk groups. So the risk adopted paradigm is very important. Management recommendations are based on individual risk assessment, and there's an increased emphasis on assessing the risk and predicting the outcomes. Based on these things, again, the evolving AJCC guidelines have told us a lot of things. Firstly, the differences, we'll see what differences have happened over a period of time. Firstly, the age cutoff was increased from 45 to 55. Secondly, minimal extrathyroidal extension, again, it is not a very very poor prognostic indicator, so it has been removed from the definition of T3 disease, right? And only on histological examination, then it does not impact the overall stage. N1 disease no longer upstages a patient to stage 3. If the patient's age is less than 55 years, N1 disease is stage 1. If age is more than 55 years, N1 is stage 2, simply put. T3A is a new category of thyroid tumors more than 4 centimeter confined to the thyroid gland. T3B is a new category for tumors of any size that demonstrate gross extrathyroidal extension only into the strap muscles. And level 7 lymph nodes, which are previously classified as lateral neck lymph nodes, N1B, were reclassified as central neck lymph nodes to be more actually anatomically consistent. And because level 7 again presented significant coding difficulties, because where it was removed, how it was removed has not been very clear. So this is the AJCC TNM. You can get these from your books and online. So all of these help us make a decision on which way should we go. Should we go for a hemi? Should we go for a total? Should we do neck, not do neck? We all know that a near total or a subtotal is a term that has to be actively discouraged, at least in terms of discussion. In practical, somebody might have left some tissue somewhere, but it is not a standard practice, and the attempt has to be to do a complete resection when we are doing a total thyroidectomy. That is the thing. So, in proven well differentiated thyroid cancers, the policy is we have to be aggressive at the extremes of age. That is, children less than 16 years go for a total thyroidectomy, radioiodine, everything. Older patients, again, appropriate aggressive surgery followed by radiation. Broadly, you can follow this, but it is again evolving. But in middle-aged adults, young adults with a low risk, we can still go for a hemithyroidectomy. So where would you go for a hemithyroidectomy? Again, it's a tumor confined to one lobe of thyroid, tumor that is not big in size. Total thyroidectomy is for a large tumor with extrathyroidal extension, multiple bilateral nodules, uh, with bilateral nodal history of radiation exposure. These are the high risk scenarios where even in smaller tumors you may consider total thyroidectomies. The guidelines are very clear that more than 4 centimeters you should go for a total thyroidectomy. Less than 1 centimeters hemithyroidectomy is allowable, and that gray zone between the two depends on the other risk factors involved. So the risk factors and the potential for follow-up determine what to do with those 1 to 4 centimeter middle tumors. Multifocality has become a chief predictor of metastasis in contralateral lobe and nodal mets, so that is an important indication. A multifocal tumor should always be treated with a total thyroidectomy. A papillary carcinoma, NCCN guidelines again say the same thing. Based on the risk categories and lymph nodal involvement, we have to make decisions regarding that. Any lymph nodal metastasis, go for a total thyroidectomy. That is the broad rule to be followed. Uh, so it's kind of funny because before 2015, when the ATA 2009 was formed, they told that less than 1 centimeter do a hemi, but for all tumors more than 1 centimeter, we should do a total thyroidectomy. Now we are going towards an era of conservation rather than actually going for a complete removal, because the risk criteria have become very well defined, and also we have come to know that the prognosis is not significantly different for hemi and total if carefully selected cases are done. Uh, so this is the what do you do in a total thyroidectomy? Firstly, as we all know, we should do a subcapsular dissection. Subcapsular dissection is very important for two things. Firstly, it would avoid unnecessary bleeding that would happen from the thyroid poles and thyroid substance. And secondly, it helps in preserving and identifying the parathyroids, which is very important. As you can see, as we go ahead with the subcapsular dissection, the parathyroid is getting separated and stripped off from the surface of the thyroid, and we are able to mobilize the thyroid medially without any trouble. We know the anatomy of thyroid gland, but just putting it right here, the superior parathyroids are fairly stable. It is located in the area of tubercle of Zuckerkandl largely. The inferior may be variable and it can occur at any places. So we have to be more careful while dealing with the inferior parathyroid, not to devascularize the supply. So this is another advantage of subcapsular dissection, where we have not clipped the inferior thyroid artery proximal to its supply to the inferior thyroid, and the recurrent laryngeal nerve goes right behind it, so we can easily identify the recurrent laryngeal nerve and then do the surgery. The superior pole, again, the superior pole is an important landmark where we should identify and look for the external branch of superior laryngeal nerve in most cases. Sometimes in smaller thyroids we may avoid it. Again, it's a practical thing. Ideally we should look to preserve it in all scenarios. As we can see, in a large goiter we will always encounter this nerve near the superior pole, and we should make every attempt to save it. Then the recurrent laryngeal nerve is to be preserved. You can see in this figure here, it's a large tumor, but the recurrent has been identified. The carotid is very well visible here. And the parathyroids. The subcapsular dissection is a technique that allows us to view the parathyroids in a proper light. This is a good picture that shows how the parathyroids have been placed and properly preserved. Uh, Other than that, the thyroid has been removed, the recurrent laryngeal nerve is seen nicely, and that is something that we need to be cognizant of. Um, an important problem when we are doing a total thyroidectomy is a risk of leaving behind the thyroid tissue. Now, if this happens, it becomes a problem for the surgeon and for the people who are following up, because your thyroglobulin levels will not accurately reflect the status of the disease inside. So, which are the points where one has to be extra careful? First and foremost, it's the pyramidal lobe. This is the pyramidal lobe. Sometimes when we are cutting too close to the thyroid, there is a possibility that we may end up leaving the pyramidal lobe behind. So look for the pyramidal lobe in all cases. If we are not able to find it, that's absolutely fine, but at least look for it properly. Then sometimes when the tumor is going far up to level 2, the thyroid is going far up to level 2, there is a chance that one may cut it off near the superior pole, near the angular portion. So at that point, again, if it is cut down, this tissue will remain in the body and that will create a problem. Same here. And another area is tubercle of Zuckerkandl, because when we are performing these surgeries as junior surgeons or somebody who has just started his clinical practice, the Zuckerkandl hugs the recurrent laryngeal nerve in many of the cases, and it is very weirdly shaped. So sometimes in order to avoid the injury to the recurrent laryngeal nerve, there is a tendency to leave behind accidentally or by design some of the thyroid tissue that is located near the recurrent laryngeal nerve. Try to dissect it nicely and try to not be afraid of the nerve. The nerve will be saved if you have identified the nerve properly, and you can trace the nerve going up to the groove. Use a good bipolar ligate it nicely, and then aram se you can take all the thyroid tissue out. This will help you, especially in malignancy cases. This will help you in monitoring and following up the patient in a better way. So as you can see here, this is the pyramidal lobe that is seen, and this is the Zucker candle. So you may cut it from here, and the Zucker candle is left behind, and your postoperative thyroglobulin is elevated. You give radioiodine to the patient, and most of your radioiodine is taken up by the remnant thyroid, not allowing it to seep through a potential distant metastatic site. Now, lymph node dissections. Lymph node dissections are not to be done prophylactically in all cases of papillary and follicular carcinoma. Central compartment sampling is optional in cases of proven CA. Again, central compartment. So, three modes of central compartment addressing have been done. Central compartment node inspection, that is CCNI. Central compartment node sampling, that is CCNS, and central compartment nodal dissection formal, which is CCND. In node negative cases, the most that you can go in T1, T2 cases is central compartment node inspection. You just see the nodes. If there is nothing, stop it, don't do anything, get out from it, and that's it. Central compartment node sampling is another thing where you clinically you may feel that there is something that is fishy. You may just take it out, send it for frozen section, take the node out, send it for frozen section, and see what is to be done. If there is a positive node, you may go for a formal central compartment node dissection. We all know why we are avoiding this. It is because there are two important things, parathyroid and recurrent laryngeal nerve, that have a chance to get injured, and we don't want to unnecessarily injure it unless it is clinically indicated, especially in cases of papillary and follicular CA where the prognosis of the patient largely is good. We don't want to poke into these regions unnecessarily. Lateral neck dissection is to be done only in strongly suspicious cases of clinico-radiological positivity. Central you may attempt in T3B or in T4 cases in all cases, yes, but other than that should not do a prophylactic central compartment also, and definitely avoid doing a lateral neck in these cases. So what are the risks and complications? Firstly, hypothyroidism is a known case, obviously, because thyroid has been removed. Injury to recurrent laryngeal nerves, hypoparathyroidism, these are the two important things that are that bother every surgeon at all points of time. What are the types of hypoparathyroidism that we see? Firstly, biochemical hypoparathyroidism, where a low intact PTH level accompanied by hypocalcemia is seen. Second is clinical, which is biochemical plus symptoms with or without the signs of hypocalcemia. Third is parathyroid insufficiency or relative hypoparathyroidism, that is clinical symptoms that require medical treatment despite the values within normal ranges. And last is a transient or temporary hypoparathyroidism, which is less than 6 months after surgery, and permanent is beyond 6 months after surgery. So biochemical, clinical, insufficiency, and temporary and permanent, these are the types. What are the intraoperative measures that we can take to avoid hypoparathyroidism? Firstly is subcapsular dissection, as we have seen in the figures that were there. Secondly, it is intraoperative autofluorescence. Now, this is again parathyroid as a characteristics of autofluorescence. So, in institutes that have the machine, again, in cases where a large amount of breast surgeries are done, they use immunofluorescence. They use fluorescence, and that probe can be used for parathyroid for autofluorescence also. That helps us identify and preserve the parathyroid in a better way. And in case you know that you have devascularized the parathyroid, don't wait for the procedure to get over. Immediately send a small saver for frozen. That will confirm your diagnosis, and as you can see that it's a parathyroid, immediately proceed to reimplant it by using a piecemeal method. On top of a bowl, just mincemeat it and then implant it. If it's a low risk tumor, you can implant it in the sternomastoid also. If it's a high risk or a medullary CA where you feel that there is a possibility of a recurrence happening at some time, brachioradialis in your forearm is also a good enough option. But it won't automatically translate to higher calcium levels immediately in the post-op. It takes up to 6 months to get vascularized. So have patience and get an endocrinologist involved at an early stage if you feel that there is a problem. Post-operative, these protocols are again different for different institutes. I have seen in Vellore where they perform serum magnesium levels at all points because they think that they feel, and there is data to support that it leads to a prognostication as to whether this thing will be done or not, whether the parathyroid will be involved or not in that. Prophylactic calcium supplementation from postoperative day 1 is a criteria, is a protocol that is to be followed. It's known as splinting, where oral calcium supplementation with calcitriol is also done. If serum calcium is less than 7 with or without symptoms, consider IV calcium at 10 milligrams slowly, which can be increased up to 150 milligram if necessary. And for refractory hypocalcemia, always have an endocrinologist on board to show up other latent causes of hypocalcemia. That's not a problem at all. Early post-operative issues may be hemorrhage, hypothyroidism. Again, thyroid supplementations are already started on day 1, so that's not a problem. Hypocalcemia is the most dreaded complication. As we said that there is a calcium that is to be managed. Management of recurrent laryngeal nerve injury. This is the most dreaded complication for a surgeon who is beginning his practice, and that is something that bothers every surgeon as he goes along. Intraoperative and postoperative are the ones that we are talking about here. Intraoperative prevention of recurrent laryngeal, right now IONM is the flavor of the day, as you would say, because that is something that has led to a very good, significantly good increase in the comfort of the surgeon in dealing with complex situation. It has not been backed by data as of now, but as the techniques improve, we are expecting that that data is also going to come, and with time it is not going to be a problem. Treatment is microneural anastomosis intraoperatively, and postoperatively, if there is a problem, we go for a vocal cord medialization. There is a small video that I'll just show that shows the benefit of intraoperative nerve monitoring. Intermittently using the nerve monitor as a guide, the recurrent laryngeal nerve is dissected away and traced up to its entry in the various ligaments. With time can be made available for counseling. The advantages of this procedure are the lesser dissection of the RLN, which leads to better preservation of blood supply to the parathyroids and lesser chances of praxia to the nerve. So as we can see that there is a graphical record that we can keep, and it is a time bound record also. So these screenshots can be attached in the patient's file just to make them also feel reassured, and you can also feel the amplitude of the vocalis muscle that is more or less similar. This is the post procedure part, right? Then the other thing that we wanted to do is treating. The treatment is to be done by microneural anastomosis. If you definitely feel that the nerve has been resected or cut down and you can trace both the ends of the nerve, there is always a role of microneural anastomosis. If the nerve is not under tension, direct microneural can be done, but if you have to resect a part of the nerve because you have to remove the tumor, you can always explore other nerves to take it and then reanastomose. Greater auricular nerve can be used, ansa cervicalis, which is quite close by, can also be used if it has not already been resected, and a microneural anastomosis has been done. A lot of experience regarding this shows that microneural does not lead to improvement in vocal cord function per se, but it keeps the muscle under active tone, so that the voice outcomes, even though the vocal cord may be paralyzed, voice outcomes over a period of time do not suffer. And it is very, very important to understand that this is the thing. This is the thing. And yeah. So that is the thing. Unilateral recurrent laryngeal nerve palsy. Unilateral recurrent laryngeal nerve palsy thyroplasty can be done. Again, this is a procedure that is to be performed 6 to 9 months after your all efforts of speech therapy have failed. So this is the end of the technical discussion. Now you can see how the risk stratification works. The static approach was, as we had known, that risk of death from thyroid cancer used to be due to Ames, AGIS, MACIS, TNM. These are all the fancy classifications that I'm sure all of my seniors who are in the panel and me also have, ratified it and involved it as our practice. Again, this was a sound approach, but as we can see that this was a static approach where there was diagnosis, surgery, ablation, follow-up. That's all, and it predicted the risk of death. Now, important part is that the risk of death is not the only thing that we are worried about in thyroid cancers. As you can see that in HSCC 1, 2, 3 and 4, death becomes a significant problem only in AJCC4. In rest of them, the death rates are minimal or absolutely nothing. But the recurrent persistence of disease or recurrence of disease varies across all things. So just predicting death in thyroid cancer is not a very wise strategy to follow. These data again showed that total thyroidectomy, again persistent disease in low, intermediate and high was obviously higher in the highest category cases. When they further discussed these data, the thing that came out was that in most of the cases in lower risk categories, the persistent disease was only biochemical, whereas in intermediate and as we went to the higher risk stages, structural disease became a significant problem. Only biochemical is something that we are not worried about, and this led to this famous chart with many of you must have seen. The 2009 ATA classified all of this and then came out with a risk category that showed the the flow chart, as you would say, or the risk assessment, where all the risk categories were identified, and based on that, low risk, intermediate risk and high risk categories were identified in long-term follow-up. So this is an important thing that is to be done. Risk of structural disease recurrence is the most important predictor for our final follow-up. How will you follow up this? Follow up for PCT and follicular carcinomas of thyroid. Again, it is institution specific, but the guidelines show that they are to be based on final histopathology, high risk cases, again RAI as indicated, and follow up based on clinical and biochemical risk stratification. In a hemithyroidectomy, there is slight T4 suppression to be done, and thyroglobulin and ultrasound, again not very reliable, but that can be practiced. In total thyroidectomies, RAI indicated or not indicated, you may decide based on the final histopathology report, and again thyroglobulin based ultrasound. And when an aggressive surgery has been performed on a high risk case, radioiodine is always indicated with thyroglobulin and ultrasound and PET scan. What is the role of RAI here? Again, ATA clearly states that in low to intermediate risk, we have to avoid using radioactive iodine ablation. Radioactive iodine ablation generally is preferred for a large extra, guidelines have a lot of statements on this, but the general practice protocol is in a gross extrathyroidal extension, in a residual disease, in distant metastasis, and in lateral neck nodal disease in the adjuvant setting, it should be used. So again, as we can see, typically recommended if significant N1B disease, that is lateral nodal disease, extrathyroidal extension, primary size of the tumor more than 4 centimeter, post-op unstimulated TG more than 10 nanogram. Again, this is for a post-operative setting, and in bulky more than 5 positive lymph nodal disease with a vascular invasion. Known or suspected distant mets is an obvious criteria where we need not wait for the histopathology report also. And if there's a gross residual disease, that is not amenable to any other therapy. Administration of RAI is generally done 6 weeks after surgery. If patient is kept on a low iodine diet and thyroxine is stopped for 4 weeks, the recommended TSH levels is more than 30 is minimum, that is mandatory for avidity of the radioactive iodine to the thyroid tissue. And the dosage of I-131 for low to medium risk disease is about 30 millicurie as mentioned in the guidelines. Generally in India, we give it on the slightly higher side. And for the higher risk disease with a larger volume of ablation or with bony metastasis, you may taper it from 150 to 250 based on your experience and clinical recommendation. Up to 250 we can safely give. What is the guidelines with regards to thyrogen, recombinant TSH? So in patients with DTC with any risk level of significant comorbidity that may preclude thyroid withdrawal prior to RAI administration, recombinant TSH is indicated. Significant comorbidities include a significant medical or a psychiatric condition that could be acutely exacerbated with hypothyroidism leading to a serious adverse event, or inability to mount an inadequate endogenous TSH response with thyroid hormone withdrawal. Coming to the follow-up, the serum thyroglobulin and TSH are the determining factors. Increasing TSH causes stimulation of latent cells elsewhere in the body. Increased TSH leads to potential to cause activation of hidden malignant cells. Hence, TSH suppression is the key here. What is the schedule that we generally follow at our institute? And this is a thing that we have broadly seen across all the major institutes, is a follow-up schedule of 1 visit every 3 months for the first year and 1 visit every 6 months after that is a reasonable protocol with TFT TG with special stress on TSH. stimulated or otherwise. Again, this is a gray zone. The guidelines recommend that TSH stimulated, the stimulated TSH should be done every time, but it is not practically possible in our scenarios. So we rely on TG, that is unstimulated basically. Ultrasound of neck is to be done every 6 monthly. And principles of TSH suppression include, as per ATA, low risk patients are to be maintained on TSH, that is below the lower limit 0.5 to 2. Low risk patients who have not undergone remnant are to be maintained at 0.1 to 0.5, and high risk patients are to be maintained at 0.1. So these are the follow-up guidelines. Now comes the most interesting topic, and this is the most important topic that all the trainees should understand, which is the dynamic risk stratification. Why is this an important thing? Because appropriate management doesn't just involve a static, as we saw in the previous thing, it was a static risk stratification. This is a dynamic risk stratification, which is the ongoing risk assessment. Appropriate management requires an ongoing risk assessment because the risk of recurrence and the risk of disease specific mortality changes as new data are obtained during the follow-up. What are the variables that may happen? Serum thyroglobulin may change, TG antibodies may change, stimulated TG, non-stimulated TG, follow-up of neck ultrasound, results of RAI scanning, cross-sectional imaging, FDG PET, all of these factors cause a variation in the response to therapy. So a dynamic response involves not just the diagnosis, surgery and follow-up, it involves response to therapy. Response to therapy can be classified as excellent, biochemically incomplete, structurally incomplete and indeterminate. So an excellent response is no biochemical or structural evidence of disease in any of the follow-ups. Biochemically incomplete response is abnormal TG with no localized disease. Structurally incomplete response is a persistent or a newly identified locoregional disease. And indeterminate response is again non-specific biochemical findings that do not correlate to the disease. Now, why is this important? This is why it is important. In cases where there is an excellent response, as you can see, there is no problems and the patients live their normal life. In cases of a biochemically incomplete response, most of the patients have no problems here, but there is a persistent biochemical recurrence that is seen, and some of them develop a structural disease. In the structurally incomplete patients, this is the problem that starts happening, where a large number of structural issues happen and there is a significant number of them who end up dying because of the disease. This is a data by Tuttle et al. Again. Uh, this graph clearly shows what we are trying to say. Biochemically incomplete disease doesn't have too poor a prognosis, but a structurally incomplete and locoregional disease that is there again has a poorer prognosis in terms of cumulative survival, and distant mets have obviously the worst kind of survival. So how do we use these things as a guideline to our clinical management? Because all of this was jargon in the absence of actual clinical guidelines as to what clinicians are supposed to do. So for excellent biochemical and structural response, we can decrease the intensity and the intensity of follow-up and TSH suppression also. In biochemically incomplete patients, we have to see that observation is to be done with a stable or decreasing TG, and if there is a rising TG, again we should have initial, additional investigations, or an empirical RAI can be indicated if it continues to increase. What's a structurally incomplete disease? Structurally incomplete disease means again there's a lot of disease that is left inside or some of the disease. So it's a case by case scenario. If a locoregional disease is found, you can always end up doing a surgery or a repeat surgery. If it's a distant mets, consider radioactive iodine in these cases. Why this is important? As we said that in a patient with excellent response, over a period of time, the TSH suppression can be slowly curtailed. Long-term TSH suppression comes with its own problems like osteoporosis, atrial fibrillation, maybe increased tachycardia, osteopenia. So this is why in those patients who have an excellent response, we can easily start decreasing the TSH suppression, decreasing the dose of thyroid that is to be given for TSH suppression, and we can allow the TSH levels to remain in the normal. So now as we see that the dynamic approach tells us that it does not just predict the risk of death or the risk of recurrence, it also involves the risk of the response of therapy. So initial follow-up and ongoing follow-up are again included in the paradigm. And now we have to see the additional ongoing risk to be considered, that is harm from a structural recurrence, harm from a biochemical recurrence, and risk of additional therapy with the risks of observation. Hence, the management in risk stratification of thyroid cancer involves all aspects of care from diagnosis to death, and not just uh, one point to the other. So there is an adequate initial data, accurate risk estimates, initial management, ongoing data collection, and continually updating risk, which leads to a guided follow-up. This is the experience-based problem. A couple of specific situations that we see here are tennis syndrome. So, if you are not aware of the full form, it is the thyroglobulin elevated negative iodine scan. That is the tennis syndrome. It is clinically defined as elevated thyroglobulin level, negative iodine scintigraphy. Empirical radioactive iodine in TG more than 10 shows uptake in 60% of the cases in the viscera. So you have to give a radioactive iodine empirically before stamping it as a tennis syndrome. If there is no uptake on radioactive iodine, then PET-CT is recommended. TG more than 100 is generally needed for a good PET-CT scan to happen, because it's an indicator of dedifferentiation, and a deep differentiation involves poorer prognosis. There has also been some detailed discussion about observation in thyroid malignancies. Generally, surgery is the go-to management, but surveillance management approach can be considered as an alternative to immediate surgery in a specific scenarios. Firstly, patients with very low-risk tumors, the erstwhile papillary microcarcinomas, which were clinically not evident with metastasis, can be done. Patient with a very high risk of surgical disease, patient with a short life expectancy, and patient with other concurrent medical or surgical. So you can buy time basically with observation, but over a period of time, there is a chance that if you are a young patient, the disease may evolve to a point where surgery may be bigger or more difficult. So in selected cases, observation is indicated, but not a go-to management. Uh, Again, incisional, the simple incision thyroidectomy remains the gold standard as of now, but minimally invasive thyroidectomy is rapidly making strides, because more and more patients are younger age group, and they are more aware of they are more conscious and aware of their cosmetic realities. So robotic mini incision, true endoscopic, and endoscopic assisted thyroidectomies are genuinely starting to happen. There is obviously the Baba approach that some of our seniors and some of our colleagues are doing. There is the post auricular, there is the post auricular approach that is used. There is also a transvestibular approach that is used, that is intraoral thyroidectomy. Again, this requires a high level of skill and expertise, and the most important dictum to be followed is that surgery should be done in a proper manner where all the principles of surgery are followed. The approach is secondary. I won't say it is irrelevant. The approach is secondary. If the experts can do it with a minimally invasive approach, wonderful, but it should not lead to any oncological or complication compromise that is to be seen. So I think we are 45 minutes into the lecture. So we will discuss medullary CA briefly. We have time. What I have done here is that I have just mentioned the statements from the guidelines and the recommendations, because it's a very confusing and a very large topic. I don't want to confuse you and more with more and more factoids and details. These are the practical scenarios that we will be facing in our practice. So that is something that we can deal with. The origin of the tumor is that it's a neuroendocrine tumor from the parafollicular C cells. They are calcitonin producing. Most of the medullary CAs are sporadic, and there is 25% of meant to be syndrome associated medullary carcinomas of thyroid. So investigations, again, they are to be carried out largely for anything. Um, Serum calcitonin and CA are important diagnostic, prognostic, and predictive biomarkers. So the recommendation is that in patients with advanced MTC, a marked elevation in the serum CEA level out of proportion to a lower serum calcitonin level of normal or low levels of both serum indicate a poorly differentiated MTC. So in a hereditary MTC, FEO and hyperparathyroidism should be excluded, because those are the syndromes that occur alongside hereditary MTCs. Now diagnosis, how do you diagnose it? So the recommendation is that USG is mandatory in all patients. CECT is based on calcitonin levels, again, uh, this is to be carefully viewed. The recommendations all tell us that CECT is to be done in those with regional metastasis or calcitonin more than 500, etc. In practical, the realities are quite different. As we said that CT scan is a mandatory thing, especially in all medullaries. So make it a point that in all medullaries you go for a CT scan regardless of what the guidelines say. The question that generally arises is medullary, should we go for a DOTA scan, should we go for a PET scan? Let me assure you that guidelines suggest nothing of that sort. DOTA or a PET is not recommended, and if you are going for it, either of them is fine as an initial mode of investigation. If you want to genuinely look for a distant metastasis, DOTA is absolutely fine. So is a routine PET CT also. FDG PET is absolutely fine. There is no problem. There is no question of an uptake, increase, decrease, because the structural disease is still there. What you would be differentiating as a DOTA would be in a scenario where you are suspecting a potential recurrence at a later date. So if you have an FDG and you don't have an F-DOPA PET, that's absolutely fine, no problems. Red proto-oncogene. Red proto-oncogene is again, it's a gray area, but have this done that any patient with sporadic MTC should have a genetic testing to determine a germline RET mutation. And if an RET mutation is found, then the patient should have genetic testing. So all medullaries should have a germline RET mutation genetic testing. Recommendation 7 again says that genetic counseling and genetic testing for red germline mutation should be offered too for genetic counseling. This is first degree relatives of patients with proven hereditary MTC, parents whose infants have a classic phenotype of M2B, and third is infants or young children with those high risk aggressive mutations. This is a very important thing, just simplifies this, right? Recommendation 24 for treatment suggests that MTC with no evidence of lymph node metastasis and no evidence of distant metastasis involves total thyroidectomy and CCND. If your calcitonin levels are high, you may go for a more aggressive surgery. But in all cases, at least total thyroidectomy plus CCND should be a minimum go-to thing. Lateral neck dissection can be done based on clinical suspicions and calcitonin levels, as I said, but there is no consensus. Generally, in MTC, the rule is go aggressive, right? You may ask for a special scenario where a 1 centimeter MTC is found and you might get away with only a total thyroidectomy. But again, it is not a standard protocol. You may get away with that situation in a specific case, that's a different matter. Recommendation 26 again says that MTC plus neck and cervical lymph nodes should have a total thyroidectomy plus CCND plus lateral neck dissection, and negative contralateral neck dissection should be considered if the basal calcitonin level is greater than 200. You see, negative contralateral, this is quite different from what we do in a papillary CA, because this is an aggressive tumor. It doesn't give us too many chances for a comeback. Advanced metastatic disease, again, extensive regional and metastatic disease, if that is present, don't avoid surgery, don't preclude surgery. Surgery is to be done, but you may involve a less aggressive approach in surgery, because in the central and lateral neck dissection, it is important to preserve speech, swallowing, parathyroid function, and shoulder mobility. So you don't want the patient to die of local or regional complications of breathing problems, but you also don't want to injure stuff, right? So go for a less aggressive surgery, but remove the disease as much as possible. EBRT, systemic medical therapies, and other non-surgical therapies are obviously to be used for local tumor control, and that's a very important thing to be done. Some clinical scenarios that many of us super specialists come across is that a hemithyroidectomy has been done, presuming that it's a benign disease. What is to be done now? So following hemithyroidectomy for a presumed sporadic MTC, completion is recommended in cases with a red germline mutation, an elevated post-op serum calcitonin, or imaging studies that indicate a residual NTC. Just an enlarged lymph node without any proof of disease in serum calcitonin or FNAC level should not mean that you go for a more aggressive surgery. Secondly, in patients having an inadequate lymph node dissection at the initial thyroidectomy and a higher calcitonin level, a repeat neck dissection is definitely recommended. It should be done. There is no harm in going in the neck again. Adjuvant IRT plays a very important role in medullary CA. It is offered to the neck and the mediastinum in patients at a high risk for local recurrence, microscopic or macroscopic residual MDCs, and extrathyroidal extension or extensive lymph node resection for those who are at the risk of airway obstruction. the, the important the important criteria that are to be followed are in a prophylactic thyroidectomy. This is the question that is very commonly asked in the exams. When would you do a prophylactic thyroidectomy in Men syndrome? So children in the ATA-HST, again this is the highest risk category with a red codon M19, M918T mutation, should have a thyroidectomy in the first year of life, perhaps even in the first month of life, because these are definitely going to develop a malignancy at a very early age. For ATA-H, that is high risk category, they should have a thyroidectomy at age of 5 years or earliest based on detection of elevated serum calcitonin level. A central neck dissection should be performed in children also who have a serum calcitonin levels above 40 picogram per ml or with the evidence of imaging of direct observation of lymph node metastasis. So, and in the children with ATA moderate category, that is meant to be with a moderate category, physical examination, ultrasound and serum calcitonin level assessment beginning at 5 years of age. So as we see, highest category first year of life, high category 5 years and moderate category, you may put those patients for observation. Follow up clearly, calcitonin and CA have to be measured every 3 monthly postoperatively, and if undetectable within the normal range, then they can be measured 6 monthly for first year and then yearly after. If post-op serum calcitonin levels exceed 150 picogram per ml, patients should be evaluated by imaging procedures including neck, ultrasound, chest CT, contrast enhanced MRI and three-phase contrast enhanced CT scan of the liver. Uh, for advanced systemic metastatic disease in patients with significant tumor burdens and symptomatic or progressive metastatic disease according to the RECIST treatment, TKIs are indicated. TKIs include vandetanib and cabozantinib, again available in India, and they can be used as single agent systemic therapy in cases with advanced MDCs. PRRT is again an is a well established treatment for advanced cases of medullary CA that have a good approach. And the final few minutes we'll be dealing with the conundrum, that is anaplastic CAs. Again, anaplastic CAs have also undergone a significant change. All anaplastics have to be stage 4 disease as we have been taught. The differences in AJCC8 are again to be seen. Unlike the previous edition where all anaplastic cancers are classified as T4 disease, anaplastic cancers will also use the same T definitions as the DTCs, and stage is of course stage 4A always, but intrathyroidal is 4A, gross extrathyroidal and nodes are stage 4B, and distant mets are stage 4C. The diagnosis involves the presence of nuclear pleomorphism, mitosis, tumor necrosis, and large invasive islands of squamous cell. Any pathologist worth his salt can easily tell us on a core biopsy specimen that this is an anaplastic CA of thyroid. FNA cytology can detect it, but if you clinically suspect a woody hard neck and infiltration in the surrounding structures, without too much doubt, go for a core biopsy, and on that you can always have a mutational testing also. If there is an AT, then anaplastic thyroid carcinoma found, then go for a BRAF 600 V600E mutation so that the treatment guiding can be done. Initial imaging should involve a CT and PET CT if available, CT of neck, thorax, abdomen, pelvis. Basically, extensive imaging is to be done in these cases. Now, which are the considerations for surgery in anaplastic CA also? Firstly, all anaplastic say 4A or 4B ATCs may be surgical candidates. The most important thing is that local control is important, but local control should not involve multivisceral resections. So the statement is that a subset of patients with 4C ATC can also be considered for surgical treatment for control of palliation. Whether a satisfactory resection could be achieved and whether the resection of involved structure results in significant morbidity in context of patient's goal for care is what determines. If you are having to do a multivisceral resection to remove an anaplastic CA of thyroid that has got a poor prognosis in any case, it is not recommended. Debulking, again R2 resection is not really recommended. Minimum R0 or R1 is what you should aim for. Radical resection, as I said, multi-resection is generally not recommended because ATCs have a poor prognosis, and a patient treated with surgery experienced a median overall survival of 6.6 months, which increased to a duration of 9.6 months with adjuvant therapy. So adjuvant therapy has to be systemic therapy, basically has to be actively included in your treatment protocols. Surgical resection of loco-regional disease may alternatively be strongly considered in patients with low volume distant mets if the local control can be achieved with minimal morbidity. What is the adjuvant therapies? Again, fractionated radiotherapy and cytotoxic chemotherapy involving a taxane, paclitaxel or docetaxel can be administered, and it is recommended in patients who are treated with definitive radiation. Uh, Again, in institutes that have the wherewithal to go for it, BRAF 600E mutated stage 4C tumors are to be done, and dabrafenib and trametinib is recommended over systemic therapies if it is to be done. So the take-home messages are that thyroid cancers form a very large variety of tumors. It's a generally good prognostic tumor, so more and more research is going into it. It does not simply involve it does not simply involve A or B. It is a dynamically evolving protocol that is to be done, and that is why we have to consider management of thyroid based on different categories. Medullary and anaplastic are aggressive tumors; they need to be treated aggressively. Anaplastic has a poorer prognosis, and that is how we should deal with it. It's a very fine surgery, but surgery is not everything. As we say that decision is more important than incision. So these are the criteria that you should follow while having a clinical practice or when you are asked in the exam. So that is it. Thank you. Uh,
Thank you, Aditya. Very excellent overview of the entire thyroid conundrum. There are few questions. One is how to select between Afirma or Thyrosic, which to be done in which conditions?
Yes, so as we said that Afirma is a largely a rule out test, whereas Thyroseq is generally a rule in as well as rule out test. Also, I would like to say that this discussion would be academic. If we were to broadly follow it, in Bethesda 4, we generally prefer a Thyroseq because we are actually looking for a rule out or rule in. But in Bethesda 3, where we actually want to rule out the malignancy, that is where you can use Afirma. But this discussion becomes academic because now there are dedicated gene analysis tests that are happening, and the panels are artificially designed. So Afirma and Thyroseq are just examples that you can use. Right now, we just need to order genetic paneling, which they find out based on our routine, our demographic setup, rather than following the Western protocols. That is what, because even now there are different companies that are coming up with newer gene panels which we are involving. So Thyroseq or Afirma, basically the principle is that in a tumor that is a higher risk, you use both rule in as well as rule out tests.
So most of the panels now includes Thyrosic and Afirma, the gene panel of both the things. So now there is no need to differentiate between them. You just order a molecular test for thyroid, and then it can be done. The issue is in India, still there is no technology to do it on FNSE slides. To bring out the RNA DNA from the thyroid slide, the FNSE slide is difficult. It's a very special technology. We are trying to develop it, but till now, none of the company in India have been able to do it, and that's why the slides and thyroid cells are sent abroad for these tests. But if you have a tissue, definitely Indian companies are able to do it, and that is the reason why whenever in India you have a Bethesda 3 or 4 lesion and if patient wants to observe, or if you conquer that this can be observed, in that case you should take out a tissue by a core needle biopsy, send it for molecular analysis, and it will be done for many companies are doing it in India, and they are comprehensive analysis.
Yes.
Second thing is the question is what is the concept behind use of thyroglobulin antibodies level in follow-up of differentiated thyroid cancer?
Yes. So basically, as we know that we do a TG based follow up in all cases, and TG, as we said, that undetectable TG is supposed to be a good prognostic feature. Now, in cases where our body itself produces anti-TG antibodies, obviously the TG levels may be artificial, may be naturally down even though there is a presence of the disease, because the anti-TG antibodies kill the thyroglobulin that is there. So even a negative report of thyroglobulin may not mean that there is no disease in the body. So anti-TG antibodies are generally preferred to be done maybe once every three TG levels are to be assessed, so that we can assess the TG levels in context or in perspective. If your anti-TG antibody levels are low and your TG is down, then it's very, very good. But if your anti-TG levels are very high and your TG is low, then you would want to go for some kind of imaging to see if there is nothing sinister that is happening.
Another question is, how much is frozen section helpful in follicular cancer of thyroid for assessment of central compartment sampling?
It is very helpful actually, because lymph node for thyroid, frozen section has got a debatable role, a limited role. But in terms of lymph nodal analysis, it can definitely say whether thyroid tissue is present or not. Because for when you are sending a lymph node, you know that if there is a lymph node that has got thyroid cells in it, it is clearly a metastasis and nothing else. So frozen section will be helpful in central compartment sampling for sure.
Aditya, there is a question from Dr. Pratap, nuclear medicine. What is the role of FAPI scan in thyroid? We all know that there is no role of PET in the well-differentiated thyroid C upfront.
Yes.
Only in radioiodine resistant disease, when they become resistant, TG keeps rising on recurrent metastatic area. We do FDG PET to identify is there a systemic mats. But what about FAPI scan instead of FDG scan?
Sir, even now the guidelines still suggest again that FDG PET remains the standard for identifying dedifferentiated thyroid cancers. FAPI, some centers have started doing it, but there are no established guidelines that are there. A couple of papers have reported their experience with FAPI, and they say that there are data that is suggesting that FAPI may be superior in detecting a lower volume TG level compared to an FDG PET. Because in FDG PET we have seen that your TG levels should rise above 100 for your sensitivity to be around 90%. Anything less than 100, it comes spiraling down. FAPI has shown, again, in I would say anecdotal cases, but in data that is of a smaller sample, that sensitivity is higher in lower TG volume disease. So if it is available freely, then there is no harm in getting it done. But if we were to follow the standard protocol, because FDG PET is much more widely available, and also a lower TG means the patient is still in a decent prognostic state, we may still wait for the PET scan to be done.
Yeah, because Dr. Pratap heads a very large FAPI therapy and FAPI scan center in Bangalore. He has one among very large experience of FAPI therapy and FAPI scan at Bangalore. That's why he asked this.
Telling us about this, so it would be bad of me to be blabbering on just based on something that I have read. So we would love to use his experience in telling us about that, sir.
Thank you. I think it was a wonderful discussion. Not just the talk. The beauty of this teaching program is our students get to really interact